Okay, so let's go ahead and begin while everyone else has a chance to call in. Welcome, everyone. This is Canel Barreto from the California Healthcare Foundation. Thanks for joining our call today. Today's topic will be partnering to combat depression. Before we begin, I want to go through a few logistical items. This session will be recorded, and the recording and presentation slides will all be posted to the CIN website, as you can see on the screen here. Also, we will send the recording and slides by email to everybody who registered. So if you have any colleagues who were unable to join us today but registered, they will also receive that material via email. Please take a moment to notice the chat box on the right-hand side of the screen. We'll use that to moderate any questions that you have during the presentation. If you have a logistical question, please use the chat to host option, and I will answer your question as quickly as I can. And if you have any questions for the speakers during the presentation, please use the chat to all settings so that everybody on the call can see the question. Ken and Loretta, our speakers today, are happy to answer questions as we go through the presentation. So if anything comes up, please put that into the chat box, and I will moderate that for them. So today's speakers I'd love to introduce. We have Loretta Jones, the founder and CEO of Healthy African American Families Phase 2. As a gatekeeper, Ms. Jones has dedicated her entire life towards the hope and healing of community and society at large. Her career as a civil rights activist, health policy advocate, and social architect has spanned more than 40 years. In an effort to level the playing field for all people, Ms. Jones continues her unyielding commitment as a change agent against disparities in human health, development, and opportunity. Ms. Jones is an assistant professor at Charles R. Drew University of Medicine and Science in the Community Faculty Prefix Series. She is the founder and president emeritus of the African American Alcohol and Drug Council of Los Angeles, and also serves on numerous advisory boards, including the UCLA Institutional Review Board for Protection of Human Subjects, the UCLA Best Babies Collaborative, president of the board of the South Central Prevention Coalition, and president of the board for the National Family Life Center and Black Women for Wellness. Ms. Jones currently resides in Los Angeles, the area she so tirelessly serves. Our second speaker today is Kenneth B. Wells, the David Weil Endowed Chair and Professor in Residence in the Department of Psychiatry and Biobehavioral Sciences at UCLA David Geffen School of Medicine and of the Department of Health Policy and Management, Fielding School of Public Health, and is affiliated adjunct staff of the RAND Corporation. Dr. Wells has led a number of far-reaching investigations into how variations in health service systems and financing affect clinical outcomes and the use of community-partnered participatory research to address disparities in depression services. Dr. Wells co-led the largest American Red Cross grant in history to support mental health recovery in New Orleans post-Katrina, and is PI of Community Partners in Care, a project we will learn more about in today's presentation. An active musician, Dr. Wells is the director of the Mansfield Chamber Singers and composed the opera, The First Lady, on the life of Eleanor Roosevelt, produced at UCLA in 2010. So as you can tell, Ms. Jones and Dr. Wells are both very accomplished, and I'm happy to welcome them as today's speakers. And with that, I'm going to hand it over to you, Ken, and you can start.
Great. Thank you very much for the introduction, and welcome to the attendees on the phone.
And welcome as well. And I link my hand in your hand, Ken, for witnessing wellness in our communities.
And this is how we begin our meetings, and often when we greet each other. And it's appropriate because today is really about using community engagement and planning to address mental health disparities, creating new bonds between healthcare organizations community organizations and community members to address especially depression. We thought we would start just to kind of set our mindset and really in many ways the community's framework for thinking of mental health with a statement of the World Health Organization. Mental health is not just the absence of mental disorder, but a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. And Loretta, would you say this reflects the kind of feedback we've gotten from the community and as we approach this issue of depression?
Yes. I think that two things happen from this. Communities feel that they are viable because they know that they can be healed and that they can reduce the stresses and become part of a community that they so desire.
The sort of the background to what we're presenting is some prior findings from a project called a national initiative called Partners in Care, which looked at the effects of implementing in primary care settings collaborative care or integrated care models for depression that built the capacities of primary care practices to address that issue with their specialty partners. And in that large national demonstration, which was quite ethnically diverse, what we found was that the use of these quality improvement programs to support primary care compared to usual care led to a high recovery rate for minorities, higher so in fact than from whites, mainly because minorities had less prior experience with high-quality depression care. So it was, there were a lot of treatment-responsive people who'd never been touched by treatment. And so African Americans gained the most, and Latinos made up about 2/3 of the existing disparity. You see in the orange that in usual care, outcomes tended to be worse with less recovery for African Americans and Latinos relative to whites, but not having that pattern when collaborative care was available and implemented. Even so, disparities persist.
And I think one of the things we want to talk about, minorities are less likely to get any or appropriate mental health care when needed. Disparities in care remains or are worsening over time because the lack of resources within the particular communities and barriers to implementation of collaborative care for depression in primary care settings, especially for under-resourced communities and the public sector clinics. And I think part of what we want to say here is that the health disparities also take care of all the social determinants of health. So that when you're looking at mental health, you must look at all of the social determinants to get what you want to see in this picture.
Right, housing, substance abuse.
Yes, safety in community, education, economic.
Right. And in addition, disparities exist in the clinical workforce, so that we particularly see less representation of African Americans, Latino Americans in the mental health specialty workforce relative to the population. And these disparities have not really been changing. In fact, they may be getting somewhat worse, and this is a more important issue as Medicaid is expanded and more minority populations with low income will be moving into insurance and have higher access to care, than having providers that can also
and I think the burden of these providers to actually get this kind of care is going to be difficult because there's not that many providers out there.
Right. So what's interesting about community engagement, which is really Loretta's field of expertise, our background briefly is that I had been a more traditional health services and policy researcher focusing on depression, and Loretta really has been a specialist in community development and engagement. And as some of those findings came out that I shared from the prior Partners in Care study, we started working together to figure out how do you bridge the gap, how do you have benefits for communities of color today, such as is suggested by these collaborative care models. So,
well, I think one of the major things is in here is getting a broader network of providers, not just the health care providers themselves, but providers of other kinds of social services within communities, whether it be parks and recreation that provide services, or curves even, but drug and alcohol programs, family preservation programs. Those folks also have an opportunity to touch this group of people and provide services to them. So to take the burden off of the healthcare provider as such.
And then many of those organizations have providers from the communities that they are serving. They're also living in those communities, yes. And so you get the greater ethnic diversity that helps with some of that capacity need.
And you improve the quality of life for the person, because they feel that as they're getting these services right in their community, that you're actually going to be addressing the social determinants of mental health as well as the other multiple sources of disparity.
Right.
Which may be housing and transportation and access to getting somewhere in a timely manner.
So the larger question that we've been working on, that we wanted to share some of our progress and findings today, is how can we translate the benefits of high-quality depression care and systems of care that support that into better lives for under-resourced communities of color today. And interestingly, just 2 years ago, SAMHSA, the main federal agency supporting substance abuse and mental health settings, did a major review of what was available and ended up saying that little was known about the independent contribution of community linkages to improving health and behavioral health outcomes. And that's really our subject today. And it's timely because of changes in federal policy and the implementation of the Affordable Care Act. What's not discussed as much is the year before the Affordable Care Act passed, the Mental Health Parity and Addiction Equity Act, another federal law passed, which required that both private plans, except for very small employers, and some forms of Medicaid plans, if they offered mental health and addiction services, had to do so at parity with general physical health. And then the Patient Protection and Affordable Care Act made those changes permanent and expanded them to additional types of Medicaid and other plans, so that there's both greater access to insurance for low-income populations, but also at parity. The insurance exchanges, for example, require mental health and addiction services at parity with physical health.
And this is a quilt of who our partners are. And as you can look at this and you can see a variety of people, from St. John's Wellness Center to Drew University to Urban League to Queens Care, who's been a very big partner, to Behavioral Health Services. Just all kinds of people are sitting at the table. And all of these people working together divide an equal partnership to learn how to improve depression care and to build community strength. And CPIC's research questions is, how can we best build community capacity to address depression? By training individual programs in best practices, maybe. By bringing programs together to plan how to implement best practices as a community. Are both models feasible? Yes, they are. Which bills provide a capacity the most? I would like to say, too, that it's bringing programs together because you're providing a strength-based project rather than somebody that's going to have individual one-on-one. And which improves client outcomes the most? I would have to say that number 2 as well is bringing all the programs together, because you then become supporting not just the individual, but you're supporting the community as well.
So this is basically the framework for the project as a whole, in that there is a partnered planning or vision stage. Some of those words look a little, letters look a little missed in the blue, but that's partnered planning vision in the middle at the top, and that's accomplished through joining the capacity for planning and services of the community with evidence-based practices and science knowledge from the academic side, and that planning then goes into the implementation, in this case, of a randomized comparative effectiveness trial between a more standard approach to giving expert technical assistance to individual agencies, which we call resources for services, or agency support, and then the comparison condition is community engagement and planning, which is a network support that is based on community engagement principles and activities, and then comparing what are the outcomes for different stakeholders, for clients, for providers, and practices and agencies, and then those outcomes are used to in a continuous quality improvement fashion to feed back to strengthen community capacity and academic capacity.
And also, when you see the word victory, it means it's a win-win. There's a win for the clinic, there's a win for the community. Models of community engagement, community partner participatory research. The principles for this are really important, that it's transparent, that you have respect for each other, that we share the power, that there's co-leadership, and that there's two-way knowledge exchange, meaning the community can provide information to the university, to the academics, to researchers, to clinics, and at the same time, clinics can then share their research. And it takes away from that word, I'll teach you, rather than I will share knowledge with you. This is a circle of influence and the model that we've used for our collaborative research approach. And in the center, you'll see the partnership, and you'll go back and look at the blanket with all of the names of the different agencies, and you'll see that the partners are in the center. And then you'll see what are resident experts. Resident experts are people who are influenced by this work, whether they be housing, transportation, health care, or in-home care, Meals on Wheels, whatever. And what happens is you want to bring the goals together so that when they set the goals, that you're setting the goals with the community, with the resident experts, and the partners. And then you want to do the planning together. And if you do the planning together, everybody feels like they have onus on it. And then the responsibilities and the authorities have to be shared. And then finally, the sharing of the information, the results, that has to go beyond just the partners or the funder. It has to go all the way out to community. And who defines community is the persons who are working in a particular area.
The fact that the outside circle is the community means that the community is, in essence, the client for this work. So in using this approach, we don't go too far without having larger forums in which we say, have we got it right? Is this are these the right concerns? Is this the way these issues would be addressed to different stakeholders in the community?
Hi, Ken. We had a quick question here. Have you come across any interventions, policy or otherwise, that have been successful in expanding the mental health workforce?
Well, I think the workforce expansion, you know, the things like loan forgiveness programs and loan programs in general have been helpful for expanding the workforce and to some extent increasing or at least maintaining the diversity of the workforce. Some new directions that are being tried now by actually some of our Robert Wood Johnson clinical scholars are really doing earlier development in community colleges and you know, where there's greater enrollment of minorities, for example, to start career trajectories into health professions earlier. And that, you know, and then we'll see how some of those trends go. But I think in the area of mental health, there's also the issue of, you know, the acceptability of addressing mental health issues in minority communities, social stigma, and really understanding that you know, in projects such as this that bring those issues forward in the community may, over time, increase.
And I think one of the things that's really important to look at is the pipeline to health, the health delivery. And it's starting now in elementary schools in my community. And on the Saturday Science at Drew University, it's actually taking small children and getting them ready for medical schools and preparing them to go into that trajectory. And the high schools as well with the STEP program that the federal government has implemented.
Great.
Great, thank you.
Oh, thank you for the question. So the next slide is the community's portrayal of the design for this study. And what you see is the coin toss. That's the chance allocation or the randomization that was featured in this study of whole programs. So this is not a randomized study at the individual level, but at the whole program level. And you can see different types of programs in each model: churches, clinics, mental health agencies, substance abuse agencies, and a community health or agency, which might be a senior center in a park. And in one picture, they're standing alone, they're in the same community, and they're being supported with expertise. That's resources for services in the top left. And in the bottom right, they're connected as a network. And what does that connection and engagement and sharing of a mindset and creating a village that's mindful of how to address depression with common skill sets and knowledge, what does that add? That's the question. This is a slide on what's in the content of some of that training, and this is common to both of the intervention conditions, community engagement planning, and resources for services in this project. There are team management tools from the IMPACT initiative. Many clinics around California have been implementing IMPACT from the University of Washington programs, and then clinical assessment and medication management tools and resources from the Partners in Care study, which are very similar to the IMPACT study. They were done close in time, those two studies. And we also added, at the request of community partners and clinics, some focus on alternative health practices to increase the engagement and to have something broader than medication alone, which which sometimes is not what people want to have. So how do you balance those issues and those preferences? Then cognitive behavioral therapy for depression is a standard evidence-based individual or group psychotherapy approach for depression. We took the version from Jeannie Miranda's We Care study that was specifically designed for minority low-income populations. And also a key feature, some argue the key feature in collaborative care, is resources for care managers or case managers or health workers. In most formal primary care models, those care managers are nurses, but in the community, nurses may not be broadly available. And in our New Orleans work, post-Katrina, we modified a lot of these materials for community health workers and laypersons to use to help coordinate care, track outcomes, develop a case registry, and sort of keep things together, and also reinforce goals with the practices, communicating with the primary care providers or the specialty consultants. Those are the kind of tasks done there. And then there are also patient education resources, pamphlets and videotapes that these care managers or case managers or the clinicians in the practices can use to give patients to help them understand what choices they have and what kind of benefits they may receive from care. So that's kind of the package of collaborative care.
The CPIC's diverse clients, we had 4,440 with a mean age of about 47. Family income was below, I think, $10,000.
For 65% of people?
For 65% of the people. African Americans and Latinos had the largest number in the project. Most of them had no resources and no insurance, which means that they had little access to health care. Very few. In my community, the unemployment rate is like 32%, and so only 23% of these folks were working. And the number of people who had high school diplomas was about 39%. Mm-hmm. And the homeless population, which was, I think, severe compared to the other part of the city, and it was high, as well as there were 28% of those who were married, and we had 54% of them which were female. And I think that you have to see it, 54%, that's kind of almost a 50-50 margin. And I want to just say that even in our diverse clients, that when they were screened, that there were a number of folks who screened severe or immediate attention. And Ken Wells and Bowen Chung and Jeannie Miranda were available 24/7 to get to those folks. That was a very important piece to this project.
So if you're working in a safety net clinic, you know, you might have a somewhat different ethnic distribution than this, but this would be a fairly typical kind of population for a safety net clinic or social services agency or mental health agency. What you may not be aware of, but then again you may, and many of the providers intuitively had this sense just from interacting with their clients, is the level of depression. So this shows the percent of clients just walking through the door on given days for screening for depression that screened as likely having clinical depression using the PHQ-8, which is, some of you may use the PHQ-9. This is without the suicide screening item. And you can see that, not surprisingly at the bottom, half of the mental health clients screened as depressed. 40% of the homeless clients in homeless programs, shelters, food lines, and so forth. 35%, which seems very high in primary care and public health clinic settings, the same number in substance abuse settings, but even in the faith-based institutions, the barbershops, the curves, the faith-based organizations,
Parks and Recs even.
And Parks and Rec,
there was a large percentage.
Yeah, almost 20% currently were depressed. So that surprised us a bit that depression was that common. This slide, the community participants in the study wanted to know every place that people were trying to get help for depression in the community, and we counted up for each person and for all of this sample of roughly 1,000 depressed people in South Los Angeles and Hollywood downtown, where were all the places and how did they fall out by the type of sector. And what you can see is mental health, which is the darker blue, was close to a third. Primary care, although 90% had some primary care contact in the year, only 7 to 8% of their total contacts around depression were in primary care, and then all the rest were either in substance abuse or the other social and community settings like faith-based, parks, barbershops and so forth, where
parenting
programs where people were struggling to get help for depression, which really, I think, kind of dramatically illustrates the importance of including community service sectors in thinking of a comprehensive community approach.
And I think that the most important thing with this is that most people don't realize is that it is a partnership between clinics and communities that takes the load off of one and, takes the burden off the other as well, so that they're able to share a patient and be able and to provide the same kinds of services together.
That's right, and if you look at those pie charts and you think about the volume of services and where they are, the primary care doctor or nurse might have 5 or 10 minutes or 15 minutes with their patient once every couple of months, and all of the rest of that volume,
see them once an hour, every
week or whatever, and they're going to church every week. So how do you get the message out to how to help someone? You want to go with where some of that volume is. This is a slide of one homeless person, and just to illustrate, and again, if you're a service provider in the community, you know this, the red up on the right is where they were living and where they were screened for depression in their homeless program. You can see, and we've listed the average bus times from Google Maps in no traffic, which doesn't exist in LA, to their services. So you can see traveling an hour to primary care, traveling over an hour and a half for social services, and it was not uncommon for homeless clients to tell us they were spending all of their time on the bus trying to get services. They had no time to get additional new services, which is one reason why you want to kind of co-opt where people are already going. This is a summary of the 6-month client outcomes. So remember, CEP is community engagement and planning, and that's the approach tying all of the agencies together through joint trainings designed as they would have it designed relative to a technical assistance-based program through webinars, quite a few. Each program was offered 12 webinars and primary care sites and in-person visits. So that's pretty intensive, but the community engagement and planning it really worked to get to people in agencies where they could. So the first thing that we found was that more staff across these agencies ended up participating in evidence-based collaborative care training in the community engagement arm. Clients improved more by about 10 percentage points in having good mental health quality of life, and also in having higher levels of physical activity, which can have other health benefits down the road. For example, that may be because the Parks and Rec senior centers with exercise programs got involved in working with depressed people.
But I think the other part of it is these services were given directly in their community, which made a very big difference.
Right.
Than having them go cross town to get something.
Right. We also had a main effect of the community engagement arm on reducing risk factors for chronic homelessness, including being recently homeless, eviction from your main dwelling, and major financial crisis, and food insecurity, also with other potential health implications. And then the rate of behavioral health hospitalizations was decreased by half, falling from about 10% hospitalization in 6 months to 5% in the community engagement arm, along with a shift away from specialty visits for medication. Same percent had a specialty visit, but fewer visits, and more primary care, faith-based, and park services, so kind of more community-based services. Interestingly, unlike our prior studies of collaborative care, there was no difference in depressive symptoms per se or use of formally designated depression treatments. It was all through what we call probably task shifting of key behavioral tasks into community sectors. We're not going to go through the particular slides in detail, in part because of time interest. Just to give you a sense, here is in the blue the percentage of all staff in the 100 programs in the study. There were about 1,600 staff, and the percent of those who got some evidence-based training, if it was in the community engagement approach, or in the orange, the standard technical assistance approach.
Can I say one thing about that? So that also allowed the community-based agencies to actually have something more to offer. When they had staff who were trained in screening, staff who were trained in the intervention arm, they were able to take and do more within the agency.
Right. Even in their own scope of work, like providing housing services, they knew how to engage that depressed person so that they could be successful in their main job. This is a slide showing the effect on being physically active and on having multiple risk factors for homelessness, where, again, the blue is the community engagement arm and the orange is the standard technical assistance arm. Here's that reduction in hospitalizations, both having any and on the right having at least 4 nights in the hospital. So this is not just, you know, being in a day or two in an urgent care center or an ER. This is a full hospital stay. The increase, you can see the same percent having a primary care visit for depression, but then those having such a visit having more visits. Here's the difference in faith-based visits, the same percent seeing, going to church, if you will, and then on the right, spending more of their time there having a visit around depression. And we've already mentioned the potential ideas. We're almost done and open for questions. So the first is that more of the basic behavioral case management and counseling may have occurred in community trusted locations. And then Loretta's point, the social service programs learned
to engage a depressed client so that they were, they had usual social services and they addressed all of the social determinants of health, which made a big difference.
Which was in their scope anyway.
Right, that's what they were doing.
Now they could do it, right?
Yes. And then the network bridged the gaps in services. So networks of people work together so that not one person carried the burden of all the services. And they were able to work across disciplines.
And if you think back to that Google map with people all over the
map going to one place and all going all these different places and getting services closer to the community, cost effectiveness is really important. Using community engagement to address disparities trains a broader network of providers that are ethnically diverse and trusted in the community. expose diverse populations to key components of collaborative care in familiar settings, and it improves the client's quality of life and social determinants of mental health.
In the Affordable Care Act, which we mentioned earlier, there's a lot of interest in promoting accountable care organizations, medical homes, the broader concept of health homes, and collaborative care programs for behavioral disorders have a lot of promise to improve outcomes and quality. The point we made earlier that many services for depressed people are outside of healthcare settings already, so why not bring them into the family and get more bang for the buck? And then, and that can be done through partnering around a common model. And Loretta's point about how health and social disparities then become jointly addressed, and it requires co-leadership, but around an evidence-based model, but needing the community engagement to engender trust.
Right, but I think both the collaborative models, if you use a collaborative model versus an individual model, the collaborative model always has people who know people, whereas the individual model, you have to hunt. It's a hunt and peck, which never is sufficient. And our partners and our funders were very important to us, so that we had the Institute of Health, the National Institute of Mental Health, Robert Wood Johnson's Clinical Scholars, UCLA, and the California Community Foundation,
National Library of
Medicine,
and
National Library of Medicine, and all of our partners, because without every one of our partners, this probably could not have been possible.
And that's our presentation. I think we came within the 45-minute time frame, and we are open to discussion and questions.
Great. Thank you, guys. That was great. And I do have a couple questions lined up here. One came a couple slides back. You shared examples of collaborative care tools, but could you also share a concrete example of these community organizations partnered or communicated with each other to improve coordination for an individual?
Okay, why don't I do this? You have a substance abuse program who saw the client come in the door. They screened the client for depression. The client also needed housing, so that needed to go to the homeless shelter, and they also needed health care or mental health care in another setting. And so that was provided. They were able to link within each other because they knew each other, and they actually had names of people that they could call on the telephone and talk to, because they worked with these people at our training sessions. So they actually were able to collaborate with each other and make relationships, build their own relationships.
The way it was, the way that got set up, the way those relationships were built is, there's actually, we didn't talk a lot about how we structured the planning process. Right. So each community was supported in having a coalition, which might be similar to the boards that FQHCs have, for example, where there are different community partners that are at the table, and a discussion of who's missing, who else is needed at the table. That coalition met twice a month for 4 months, and they were asked to talk about how they currently provided services, what the gaps were. They were asked to review a set of standard toolkits, like the one I listed, of collaborative care, and to think about what it would mean to use those toolkits. For example, if you do case management, I may do medication management, or who are our therapists, or do we have any therapists?
And do we have people who provide transportation to get people back and forth to places? So it's a whole collaborative process of finding out what each person has to offer. How do you get to it? You know, what ways do you get to it? We also, for everyone, they were given a resource manual. And that resource manual listed housing, how to get food, places, because we knew that people were going hungry, so we need to make sure that there was food places. We knew where there were clinics at. We knew where there were places to get such things as clothing and furniture if they needed it for their place to live in.
And at the end of the 4-month period of time, each coalition was asked to do a written plan for what their community plan was in this area to work together as a network, and then what kind of training support they wanted. And then the experts in collaborative care worked with the community coalition to implement that training plan. So, for example, they may have wanted a series of 2 or 3 large conferences, half-day to full-day conferences, to introduce people to all the components of collaborative care. They may have wanted intensive supervision on cognitive behavioral therapy or case management for core leaders in the community. They may have wanted outreach visits to make sure that staff that wanted to be trained but couldn't leave their jobs to go to a conference had an opportunity to have some training, at least in their own agency. And that was put together into a plan, as well as how to distribute the resources, like the resource guide that Loretta mentioned. And all of that then got implemented over roughly a 4 to 5 month period of time, and then clients got supported by those toolkits. An example of a client that may have gotten a different kind of service is a senior citizen with depression in primary care. The primary care provider, well, I can prescribe medication, but you really need to become more active. There's a park with a senior exercise program that can help you, that knows something about depression also, just 2 blocks away. Let's set you up for a visit. And then you tie in the social support, the exercise, which alone we know can be a big factor in relieving depression.
Great. And I think you touched on this a little bit, but could you talk more about the case management training and what that looks like?
The case management training had these following components, and we have a website that explains this for community partners in care. So we had supports for screening and depression and how to engage people in screening, and also using that screening to track depression over time. There was a case registry for people to facilitate that tracking. There was skill building in basic behavioral skills, such as what we call behavioral activation, which is getting people to return to pleasurable activities. It's a component of cognitive behavioral therapy that has a lot of general applicability, and also problem solving. One of the skills, one of the issues in depression is people stop solving their problems, and the usual approach in case management in the community is then for the caseworker to solve the problem for the client. But the idea in problem solving for depression is take a small problem that person with a little support can solve themselves, even if it's not solving the whole problem. Reinforce them for that, and then take the next step, unless it's an emergency situation. So that's a whole approach to supporting people's own competence.
I think the easiest way to say it is catch it, check it, change it.
Yes.
And that's what we've taught the community.
Great. I think that's a great way of putting it.
To catch
really quickly,
the problem and look at it and see if it's something you can solve or something you can't solve. To check it to make sure that it's there, and then to change it if necessary by doing something such as so small as to take a walk around the block, to something greater than let me go get my hair done or let me go seek out a counselor. But it allows the patient to actually have control over what they determine are their problems and how they can best address them, and that they have a support system around them. Is that helpful?
Yes, absolutely. Thanks. And before I go to the next question, I just want to ask everyone on the call to notice we just opened a poll, and we'd really like to get your feedback about today's call and also any feedback on future topics that you'd be interested in hearing about. So the next question I have here for you, Ken and Loretta, is for the IPAs, medical groups, and FQHCs on the phone today. What first steps would you recommend as they think about engaging community partners for the first time?
I would say first find out where their community partners are, and then have some kind of a mixer that brings the community partner to them or them to the community, where they can actually just meet for the first time and get to know what each other has. And then the next step is to have a formalized meeting.
I think it's very helpful to identify, many IPAs and FQHCs probably have some community liaison that they have worked with. If there is a community liaison that can help them strategize, someone who really understands the community.
On their board, someone on their advisory board. It could be anyone, including their nurses or their outreach workers, anyone. So right. They have to find internally who has the connection.
There might be a local school or a faith-based organization, someplace that's trusted in the community. Even asking some of their patients if they...
Who do you go to?
Who do you talk to?
Where do you get your services from?
And then offer a lunch.
Right.
And say,
lunch
would you
is always good.
Come advise us, and we'd like to hear your thoughts about how we could start a community action board.
And I always say to have that relationship meeting first, where you can actually, before you get into personalities or anything, you just have a hi, how are you? And this is who I am, and I want to know who you are. And then ask, can you please join? Because that way I have a vested interest. I already know something about you, and I'll get a vested interest in what you're doing and want to be a part of it.
Right, and remember, Loretta made the point about the win-win at the very beginning. In engaging communities, understanding fairly early on what's in it for them. Everyone will be interested in helping the community, but many organizations, let's say faith-based organizations, may feel we send our patients to you, they go to the hospital or whatever, we never get any direction back, and we're the ones supporting them and their family when they're back in the community. So they may simply want a connection or information or that sense of continuity. Understanding that can help bring them to and keep them at the table.
Well, great, thank you. I think that was the last question. If anyone has any last-minute questions, please chat those in now. Thank you again, Ken and Loretta. This was great, very informative, and I find it very personally interesting. Again, I want to remind everyone on the call that this recording and these slides will be posted on the CIN website that's listed here, and I will also be sending those out via email for everybody who registered.
And I think if anyone should want and need to call either Ken or myself for any kinds of questions or technical assistance, we'll be glad to give it.
Right, and there's a HRSA announcement out now for integrated care resources for FQHCs that are funded by HRSA, and these kind of collaborative care programs and community connections are, maybe important to bear in mind. The letter of intent phase is already passed, but if you've done a letter of intent, then you're now preparing your application, and some of this could be what you ask for support to do.
Great. So then, if that's okay with you, I will send your contact information with the slides in case anybody has any follow-up questions.
Good idea.
Great. Well, thank you everybody for joining, and have a great day.
Thank you.
Sure, thank you.
Thank you. Bye-bye.
Bye.